be suitable for a patient who needs the follow-up and care, as a superficial knowledge of the general condition and the symptom progression cannot guide the further treatment. To make a diagnosis, the clinical examination in a surgical field is most important, as is a must. Another problem we face is that telehealth lacks the human touch, one of the main prerequisites of an effective doctor and the patient relationship. Additionally, teleconsultation faces the reduced opportunity to show empathy to the patient, understand their needs, and adequately counsel them. Difficulty with appointment and consultation time is there, which has already been told by the Chief Medical Officer also, that phone calls at the inappropriate time may contribute to a lack of interest in teleconsultation, and a contributing reason may be there for some of the patient which may decline such services in the first place.
Can I request, in view of the time, we have, can you please conclude?
And last is that data security and privacy, that remains the main, another important part, that data provider apprehension about data that already has been informed by that AI people, that they will take care of that. There is no option to know if the mobile health application development has taken the necessary precaution to ensure the privacy and security of the application against the malicious attacks. Thank you very much.
Thank you, Dr. Abdul. Yes, challenges are always going to be there. We need to project some good success stories so it catches the imagination of the public. So I'm going to get Dr. Amit, who is the cardiologist, and he's going to talk about success stories from cardiology, which has helped saving lives. There are many projects going on in telecardiology, and there are some real good examples of how lives have been saved at the nick of the time. So Dr. Amit, you're on.
Yes.
You have about 5 minutes, since we're running a little late now, getting into, past the dinner time, 8 o'clock is supposed to finish. But we started half an hour late, so I suppose they'll give us some grace time. And then we have Dr. Vani, who is going to talk about her experience and her case studies, and in the end we'll have the AI application. Future. Yeah. Amit.
So good evening, everyone. At the outset, I'd like to thank the Telemedicine Society of India for giving me an opportunity to talk in front of such an august audience. So my topic will be more concerned in cardiology. Since we are operating a hospital in Dharamshala which has a cath lab, so many of you have heard of hub and spoke model. So we act as a hub hospital, and spokes are the obviously peripheral health centers. So why CVD is peculiarity in Indians? Why CVD is important in Indians? Why? We have a very higher relative risk burden in India. We have an earlier age of onset, and we have higher case fatality. And of course, we have higher premature deaths. There is a common term that Indians have a heart disease 10 years earlier as compared to the West. And how telemedicine helps in that? We'll just talk about that. In cardiology, we have emergencies and we have stable heart disease. Emergencies in the form of acute coronary syndromes, and stable heart disease, stable CAD, and of course, patients of heart failure. My talk will be more with concern of acute emergencies in the form of ACS. Guidelines say in acute coronary syndromes, in STEMI and non-STEMIs, primary PCI should be done. That is the gold standard. Why I'm saying so? So we have conducted various studies where they say if we delay the reperfusion by 30 minutes, there is an 8% increase in 1-year mortality. So there is a common term used in our in cardiology practice, time is muscle. So we have to be very quick in that. So my earlier speakers have spoken about hub and spoke model. We also follow that model in cardiology. Hub is a cath lab enabled hospital, and spokes are the peripheral health centers, private clinics, where patient presents, that is FMC, first medical contact to a peripheral health center, where an ECG is done, and the ECG is being relayed to a hub hospital, where ECG is being read by a cardiologist, and he guides them what is to be done further. Now comes the major issue. In Himachal, we have a problem in transportation. It takes time to reach to a hospital. But as per guidelines, if a patient can reach to a cath lab equipped hospital within 2 hours of first medical contact, he should be offered a primary PCI. Thrombolysis should not be done. But if patient cannot reach to a primary health, to a hub hospital, we should offer him thrombolysis at a peripheral health center and make sure patient is being followed up. What we do is we tell the person at the periphery, you get an ECG after a thrombolysis. If there is ST segment resolution and patient is pain-free, get a routine angiography within 24 hours. But in case many a times thrombolysis is failed, patient continues to have chest pain, we label it as a failed thrombolysis. Then we tell them send the patient immediately to a hub hospital and get a PCI done. It is very important since we have to maintain the perfusion of myocardium, otherwise patient will develop LV dysfunction and will have a poor prognosis. So this we do in stable coronary artery disease, heart failure patient, atrial fibrillation patients. We can do telemonitoring. How? Patient can send from the periphery their blood pressure, their smoking history, diet, weight. Weight is especially important in heart failure patients. We can monitor their weights. If the weight is increasing, we can increase the dose of diuretics. If it is increasing, we can address accordingly. Medication adherence can be checked whether patient has been taking his medicines regularly. And of course, home ECG. It is a very important. Nowadays, we have all Apple iWatch where it has been seen many times, many lives have been saved by getting a simple ECG from Apple iWatch where many times atrial fibrillation has been detected. Pulse oximeter, and of course nowadays we have a pulmonary artery pressure monitoring in heart failure. That is a cardio-MEMS system. That is not so much so vogue in India, but in West it is being frequently done where they measure the pulmonary artery pressures in heart failure patients and guide their treatment accordingly. So I'll be telling you some success stories. Talk has been done, it is more of a success stories. This 29-year-old gentleman presented to us with complaints of chest pain. He was roaming in McLeodganj. He had a chest pain, went to a peripheral health center. And we have a WhatsApp group of our hospital where all the peripheral health doctors send our ECGs, we guide them. That is the role of telemedicine. So luckily that doctor was in our group. He sent us the ECG. And ECG was showing massive anterior wall infarction. He presented to us within 30 minutes. We took up the patient to cath lab, and when we did a coronary angiogram, we found a huge clot in his LAD artery. We did not thrombolize him. We offered him primary PCI, and he happily agreed to that. And post-procedure, there is a term door to balloon time in cardiology that has to be achieved within 60 minutes. We did this procedure within 30 minutes. ECG changes settled, patient was pain-free and was discharged on the third day from hospital admission. So this is another story. This is a lady, elderly lady from Chilgadi. He was having some epigastric burning sensation since 12 a.m. in the night. She ignored the symptoms, took some antacids and all things. Went to a local practitioner at around 5 a.m. where she had to knock the private practitioner clinic, and he did an ECG. And ECG was sent to us, relayed to us via the WhatsApp group. We replied to that. We activated our cath lab. We took up the cath lab, and we did this primary PCI early in the morning. We stented his right coronary artery, and patient was pain-free. This is the last case I'm showing you. This lady presented to us from Beer Billing. There's a primary health center in Beer Billing where an ECG was done. Patient presented there. Patient was complaining of chest pain, dizziness. ECG was suggestive of inferior wall MI with complete heart block. The ECGs was already relayed to us. We had already activated a cath lab. Patient reached to us within 1 hour. We directly took him to the cath lab. Did our angio, we found that RCA was completely blocked at the crux. We initially put a temporary pacemaker, and then we did a primary PTCA. We constructed the whole RCA, and post-procedure, you can see the difference in the ECG. The complete heart block completely resolved. ECG remained, ST segment came down, and patient was pain-free. Temporary pacemaker was taken out the very next day, and patient was discharged from the hospital on the third day. So the idea I'm trying to convince to the young fellows, you all will be going out to the periphery for working. Make sure if a patient presents you at a periphery, this is a common emergency you will see. If a patient presents to you, and if you can send the patient to a cath lab equipped hospital within 2 hours, please make sure do that. Don't thrombolize the patient. But if you feel that patient cannot be shifted to a cath lab equipped hospital, thrombolize it And please make sure he goes to a cath lab hospital within 24 hours and get his angiography done, since thrombolysis is not the definite treatment. Primary PCI or PCI, we have to open up the artery. Even if it's thrombolized, clot will still be remain, some clot will be there, some blockage will be there. We anyways have to fix the artery and get his angiography done within 24 hours. Thank you.
Thank you. I mean, great examples of how lives have been saved. Can I request Dr. Vani Sharma to, she's a gynecologist and has 19 years of experience. She was the first to introduce, gynecoendoscopy in her district, many first to Pradesh, and she's been using telemedicine, telehealth to make a difference in the lives of a patient. Yes, Dr. Vani.
Once again, very, very good evening to everyone, the panelists, the principals, sir, the additional directors, sir, other dignitaries, and all the students present here. I would like to extend a heartful gratitude to TSI Himachal chapter to have allowed me to stand here in front of such an august gathering and put me on and allowed me to put my points in my area of OBGYN. So, to begin with, we all know that OBGYN in decades, antenatal care means in high resource settings also means almost 10 to 12, 14, 15, 16 visits, face-to-face visits across throughout the pregnancy. But COVID-19 pandemic has forced many care providers to rapidly embrace telehealth to reduce face-to-face visits. And here we just give some examples and how we use it in our day-to-day practice at our center. So, first, why do we use telemedicine in OBGYN? Of course, the access to specialized healthcare. When the patient is at a remote center, she is under the guidance of midwives. But if a patient is under the guidance of a specialized clinician, then of course it makes a lot of difference in the patient outcomes, especially in OBGYN, where we can pick up the high-risk pregnancies early, we can manage them early, and we can send them to tertiary care centers early. So that not only promotes early diagnosis and treatment at the doorstep of a patient, but also reduces the travel cost. I think these points have already been covered, but just to re-enumerate them, reduces the travel cost, especially in this terrain, reduces the visit and the visits and waiting hours that pregnant women have to sit for long hours outside the OPDs. And that is also a very, very big issue with some patients. And reducing the burden of morbidity is another benefit that patients might have through the use of telemedicine. So what is the benefit to the clinicians as the OBGYNs? What benefits do we have? Better monitoring and better outcomes. So better monitoring in the sense that if you cannot call the patients for BP monitoring, fetal heart monitoring every other day, but in telemedicine you can do that every other day. So that is one major advantage that we as OBGYNs do have in this area. Increased patient compliance. Once a patient visits you, it's difficult to connect to her for at least a month till she visits you for her next till she visits you for her next consultation. But with the use of telemedicine, somehow there has been a study in the British Medical Journal in 2023 where the patient compliance has drastically increased after the use of telemedicine. So patients can use as and when according to their convenience and not according to the convenience of the dates given to them for the next consultations. The timely post-discharge follow-ups. Now many patients, once they go out from your OTs and post-op areas to their homes, they do not come for follow-ups, especially the C-section patients, as the distances are too long in Himachal Pradesh. So when we connect with these, in our hospital we have a mother forum where we connect to these patients on WhatsApp, and they send us their wound pictures, they send us their issues relating to the postpartum period. So we really involve ourselves in managing these patients with our WhatsApp. So this has really given us a very, very good and a timely post-op discharge follow-ups, and this has been instrumental in developing better follow-up protocols for our institute. So the access of comprehensive patient data both online and offline. Now whenever a patient is doing a teleconsultation, the data is building up. So you can use this data for your studies, retrograde studies. And that is one important point that probably telemedicine will be helping us. Then continuance of medical education and training has been made easy. So that is another thing which a lot of us has experienced also. Like CMO sir said that midwives and all, they are being trained to use telemedicine. So, why do we need telemedicine in OBGY in Himachal? Of course, this points Dr. Rita has already discussed, but just to throw a light and give continuance to my slides, high cost of healthcare and lack of investment for health in difficult terrains, as discussed by Madam, inadequate medical facilities along with inaccessibility issues at the higher altitudes, and the third most important problem of retaining doctors in these areas, retaining specialists even after monetary incentives as they feel professionally isolated. So, what is the role of what is the role of telemedicine and how we use in our practice? One is the clinician to patient virtual visits. That is when you make a direct call to the patient, or the patient makes a direct call to you for an online consultation. So that is the virtual home visit where you can prevent the face-to-face visits, and patient can come only for the milestone visits in OBGYN. Milestone visits refers to the one visit in the first trimester, another at around 28 weeks and another at around 36 weeks of pregnancy, where you have to plan the delivery. Then special reference to the low-risk pregnancy care. Low-risk patients can be easily managed, and all we require is just a BP apparatus. Maybe if a telemedicine hub is nearby, we need a fetal heart monitor and we need a measure tape. So they can just send us our records, and we can keep monitoring these low-risk patients at our own center, though they are situated very far. So that again is another advantage. So postpartum care, as I've already explained through the WhatsApp forums and the use of smartphones and all, we are practicing this at our center. And lactation support. This is one area which has been overlooked for years in a lot of settings, but with today's demanding patients, they need everything. They need a physiotherapist, they need a dietitian, they need lactation support staff. So we have trained certain staffs, and we have a lactation forum at our hospital. We are using this for supporting our patients postpartum and also helping them psychologically, because postpartum phase, as we all know, is the most difficult phase a woman would have during the journey of her pregnancy. Then of course the routine consultations and the post-operative follow-ups. Then access to super specialist care in OBGYN via telemedicine. How do we do that? Genetic counseling. We at our center are using telemedicine for genetic counseling from people from the states, other states. We also use fetal medicine consultations. I'll just give you an example of that. We recently had this patient who was from Bharmor. So nearby center, she never had a antenatal visit in the first trimester. She came to us at 18 weeks. Of course, it was time for her to get her level 2 scan, the anomaly scan. When the anomaly scan was done, the baby was found to have congenital airway malformation. So she visited other clinicians on the same day, took 3 to 4 opinions, and everybody was of the opinion that the baby should be aborted. But then I said, wait, we go for telemedicine. We consulted a telemedicine doctor, far-fetched from our area. So we don't have anyone here right now in the district of state of Himachal. The telemedicine, after the telemedicine consultation, the patient's faith was redeveloped that she could continue this pregnancy. And just recently, she's almost 36 weeks now. We have referred her to PGI on time. She has delivered yesterday, and the baby is doing fine. So the baby is in advanced NICU care with some distress. So that is how we could, help this patient. That's where fetal medicine will come in. Fetal medicine consultations can come in quite handy, sitting here and using fetal medicine for the benefits of our patients. Then comes the infertility management. Many of our patients are taking treatments from outside our domain or outside our district. So these patients come for follow-ups at times. So if we can connect them, we do ourselves also do some infertility, but certain patients require some specific care. So these patients, if can be connected through various channels to their primary physician, then it's a great help. And similarly, the endocrinology consultations. The second opinion for MRI reports, we are using this on a routine basis. We are sending our MRIs to other centers for second opinion, because this definitely helps planning our surgical part, and also counseling the patient better when it comes to endometriosis. And role in gynec oncology for treatment and planning with multiple disciplinary consultations, like online tumor boards. This is another area where gynecology, where telemedicine can be used very effectively in OBGYN. As far as monitoring of the patients is concerned, disease management, which includes diseases, chronic diseases like PCOD, endometriosis, they can all be managed on online consultations. Antenatal testings, if somebody has a telehub nearby, we can just write them the various investigations and they can go there and get them done and then show back to us. And fetal heart monitoring, if we provide certain gadgets to our patients, there are handy watches coming in with fetal heart monitoring, the CTG machines, the handy fetal heart monitoring devices, and even the wearable smartwatches which are doing this fetal heart monitoring, which can really be help to these patients. And timely transfer of these cases. Yes, sir.
If you don't mind, we are really running very late.
Just sir, I'll conclude in 2 minutes, sir. Timely transfer.
1 minute here, madam. So sorry, because we are running very late. We are kindly conclude.
I'll conclude it, then I'll not be going to the challenges.
Thank you so much. Sorry about that.
No issues, sir. Conclusion, I just put a brief conclusion here. Adoption of telemedicine technologies may improve the antenatal care experience of women and reduce healthcare expenditure without adversely impacting health outcomes of mother or baby. More studies are warranted to confirm that telemedicine does not alter the risk of rare outcomes like maternal mortality or neonatal morbidity. That is all. Thank you so much for patiently.
Thank you to interrupt you. So we are late, but we've been having an interesting session. We're going to conclude with the future direction, and Dr. Sachin Verma from the Budget ICU is going to speak. Sir, you have about 5 minutes because we're a bit late and we still have work to do. Thank you. I can only say that telemedicine is one area which unites so many specialties, brings them all together. Otherwise, when you go to an eye care conference, you only see ophthalmologists. When you go to a gynec conference, you only see gynecologists. On this platform, we have such a variety of people. Please, Dr. Verma, Sachin.
So, good evening, everyone. First of all, thank you, TSI HP, for giving me an opportunity to come here and share my thoughts with you. I belong to RODO and I am AIIMS 2001 batch MBBS. So, this is a kind of homecoming to me. All the experts have said, nothing left to be said. So, I'll be telling stories. सबको stories हिंदी में सुनना पसंद आता है. So, mode of communication will be both Hindi and English. So, किसी भी MD मेडिसिन ने नहीं बोला अभी तक, सब स्पेशलिस्ट ही थे. आई एम MD मेडिसिन. और अगर हम बात करें कोई भी MD मेडिसिन, अभी इस टॉक के बाद अगर मैं अपना फ़ोन उठाऊंगा तो कम से कम 10 पेशेंट्स के व्हाट्सएप मैसेज होंगे कि सर ये 20 पेजेस की या 40 पेजेस की मैंने रिपोर्ट करा दी है, इसको बता दो क्या करना है. सो आई डोंट नो वेदर दिस इज हेल्पिंग अस आउट और इट इज़ बर्निंग अस आउट. MD मेडिसिन की तो जान निकल गई, वो 40-40 पेज की रिपोर्ट्स फ्री में बताकर. सो आई बिलीव दिस इज़ अ सॉर्ट ऑफ टेलीमेडिसिन. पर जिस टेलीमेडिसिन की बात मैं करना चाह रहा हूँ, सो आई एम टॉकिंग अबाउट अ बिगर थिंग. So, Budget ICU is my company. We run ICU, 20 ICUs in peripheral centers in Punjab and Himachal. Mr. Ajay from my team has said, technological aspect he has said. I'll be talking from a doctor perspective कि technology company बनाने के लिए challenges क्या हैं. और वो real challenges हैं, because first challenge in adoption of telehealth is mindset of doctor. We talk about IQ, we talk about EQ, digital IQ के बारे में, डिजिटल क्वोशेंट के बारे में तो कभी बात नहीं करते हैं. कितने डॉक्टर्स हैं जो कहते हैं कि मुझे टेक्नोलॉजी समझ में आती है. आई डोंट नो एनीबडी विल से, एवरीबडी विल से व्हाट्सएप तक तो अपने को पता, उसके बियॉन्ड नहीं अपने को पता. जूम कॉल पे कोई सेट कर देगा तो हम बोल सकते हैं, उसके बाद दैट इज नॉट टेलीमेडिसिन. सो माइंडसेट ऑफ डॉक्टर्स इज द बिगेस्ट इशू, और उसमें डॉक्टर्स की गलती है नहीं. देयर इज लैक ऑफ एक्सपोजर अबाउट टेक्नोलॉजी इन अवर सेटअप. अभी भी एक टेक्नोलॉजी की टेलीमेडिसिन की कॉन्फ्रेंस है, बट किसी ने भी बच्चों को ये नहीं बताया कि टेलीमेडिसिन शुरू कैसे करनी है. वो तो सबसे ज़रूरी था ना, हाउ टू स्टार्ट. व्हाट्सएप थोड़ी ना टेलीमेडिसिन, जूम कॉल थोड़ी ना टेलीमेडिसिन. सो देयर इज़ लैक ऑफ एक्सपोजर अबाउट टेक्नोलॉजी. और एक बच्चा जब MBBS करके निकलता है, फिर MD करता है, वो 25-26 साल का तो वही हो जाता है. उसके बाद अपना करियर सेटल करे, फिर वो SRship कर रहा है, वो टेक्नोलॉजी सीखेगा कि वो हेल्थ केयर भी उतनी ही तेज़ी से ग्रो कर रहा है जितनी तेज़ी से टेक्नोलॉजी ग्रो कर रहा है. नाउ ही इज़ कन्फ्यूज्ड कि पहले टेक्नोलॉजी सीख लें या अपने करियर को सेटल कर लें. एंड देयर वी आर लैगिंग बिहाइंड विद हेल्थ टेक कंपनीज. और फिर मेरे जैसा आदमी कोई सोच ले कि टेक कंपनी स्टार्ट करनी है, देयर इज डोंट नो हाउ टू स्टार्ट अ टेक कंपनी एंड देयर इज लैक ऑफ फंडिंग। सिर्फ व्हाट्सएप कंसल्टेशन से हम बोले हम एक ऐप बना लेंगे। सो आई रन 3-4 कंपनीज। सो वन ऑफ माई कंपनी डील्स इन लैब्स। सो हमारे पैथोलॉजिस्ट ने बोला सर एक लैब के लिए ऐप बना लेते हैं। तो मुझे नॉलेज आई टोल्ड हिम सर ऐप बनाने से थोड़ी ना टेक्नोलॉजी कंपनी बन जाएंगे हम। उस ऐप को चलाएगा कौन, जब लॉगिन फेल हो जाएगा उस लॉगिन फेल को कैसे मेंटेन करेंगे, पेशेंट्स के डाउनलोड्स कैसे कराएंगे, उन डाउनलोड्स को मेंटेन कैसे करेंगे, उन आप एक ऐप बना लेंगे और वो उस ऐप को डिलीट नहीं कर देंगे, वो कैसे इंश्योर करेंगे, हर दिन उसमें नए फीचर्स कहाँ से लाएंगे, वो डॉक्टर कैसे करेगा वो। सो देयर इज सिग्निफिकेंट इशूज। और उसके लिए अगर हमें टेक टीम रखनी हमारे तो अपने लाले पड़े हुए, टेक इतने कॉस्टली लोगों को कहाँ से हम हायर करेंगे। सो देर आर ह्यूज इशूज फॉर डॉक्टर्स। हम टेक एक्सपर्ट बने कैसे, हम तो फंस गए, ना इधर के रहे ना हम उधर के रहे। इंटरनेट कनेक्टिविटी रिपोर्ट एरियाज इशू, बट अब सैटेलाइट इंटरनेट से प्रोबेबली इशू सॉल्व हो जाएंगे। स्टारलिंक, एलॉन मस्क के बारे में सबने सुना होगा, तो हिज कंपनी स्टारलिंक इज डीलिंग इन सैटेलाइट इंटरनेट। अभी अंबानीज को भी मिल गया कॉन्ट्रैक्ट, तो होपफुली विद सैटेलाइट इंटरनेट करेंगे ये इंटरनेट कनेक्टिविटी इन रिमोट एरियाज का इशू सॉल्व हो जाएगा। एंड देन वी नीड ए रिलायबल टेक्नोलॉजी पार्टनर। हमने बोला हम टेक्नोलॉजी का पार्टनर बना लेते हैं। मिलेगा कहाँ से? हिमाचल में आप देखो टेक है कहाँ पे, इंडस्ट्री है कहाँ टेक्नोलॉजी की इंडस्ट्री? चंडीगढ़ में भी नहीं है। लकीली आई फाउंड अजय जी इज बेस्ड इन नोएडा। सब कोई मेरी तरह किस्मत वाला भी नहीं होता, बट देन देयर इज अ ह्यूज इशू इन नॉर्थ इंडिया। सो हाउ डू वी ओवरकेम? अब मैं सिर्फ प्रॉब्लम स्टेटमेंट नहीं बताना चाहता हूँ, मैं सॉल्यूशन भी बताना चाहता हूँ, बिकॉज आई ओवरकेम दोज सॉल्यूशंस, आई ओवरकेम दोज प्रॉब्लम्स। मे बी उस स्टोरी से कुछ इंसाइट्स मिल जाए, मे बी टू द न्यूअर जनरेशन who want to start a health tech company. So talking about a बिक्कू story, budget ICU story, not a sudden बहुत लिमिट कर दिया मेरी टॉक को। So very short story. So I was a critical care department head था मैं infectious disease का in a corporate hospital. So a top practicing infectious disease specialist, COVID wave 1 में जब lack of beds होने लग गए, and at that time we were charging 1.5 lakhs per day for a bed. Second wave तक I was burnt out and then I started my own hospital. तब वो डे केयर वेंचर था, उससे पहले भी मैं टेलीमेडिसिन में एप्स बना चुका था। सो आई हैड एक्सपीरियंस इन दैट। सो वी थॉट ऑफ कि कैसे इस हेल्थ केयर की कॉस्ट को कम करना है। सो वी थॉट ऑफ बजट आईसीयू। उसके लिए हमने मल्टीपल चीज़ें कर ली। हमने ABGs की कॉस्ट कैसे कर सकते हैं, क्या हम एक्सेस कम कर सकते हैं। तो somehow we did those benchmarking and then we need to scale. अब हमें लगा हमने एक ICU बना लिया, बजट ICU, brought that cost of critical care from 70-80,000 पर डे जो अभी एवरेज कॉस्ट है टू 15,000-20,000 पर डे, वहाँ तक हम ले आए। एंड देन वी थॉट ऑफ अब हम इसको स्केल करते हैं। अब हमने एक मॉडल बना लिया, अब हम जगह जगह ICU खोलेंगे और हम अमीर बन जाएंगे। और देन वी रियलाइज कि यार इंटेंसिविस्ट तो है ही नहीं। There was a significant dearth of intensivist in India. इस वक्त इंडिया में सिर्फ 50,000 से भी कम इंटेंसिविस्ट। हमें लगा यार मैनेज कौन करेगा ये ICU। देन वी रियलाइज नर्सिस, अरे नर्स को तो अब हमने वेंटिलेटर वहाँ लगा दिया और पेशेंट को बीन कैसे करेंगे हम। सो देन वी रियलाइज कि यार दिस इज़ नॉट द वे टू गो। और यही एक मेन रीज़न है दैट ICU बेड्स आर लैकिंग इन इंडिया। देयर आर नो पीपल टू मैनेज। 150 करोड़ की पॉपुलेशन के लिए सिर्फ 48,000 वेंटिलेटर है। वेंटिलेटर तो खरीदे जा सकते, उसको चलाना भी तो आना चाहिए। पेशेंट को वेंटिलेटर पर डाल के उससे निकालना भी तो आना चाहिए। सो देर आर अप्रॉक्सीमेटली 95,000 ICU बेड्स इन इंडिया। और देन वी रियलाइज कि सम हाउ टेक्नोलॉजी हैज़ टू टेक ओवर। यहाँ पे हम एक सेंट्रल हब बनाएंगे और हम पेरीफ्री में ICUs बनाएंगे। एंड देन फ्रॉम टेलीमेडिसिन वी ट्राई टू सेटल दोज इश्यूज, क्योंकि फिर हम उस कॉस्ट को कट कर पाएंगे कि हमने 1-3-4 लाख का इंटेंसिविस्ट सेंट्रल जगह पे बिठा लिया और उसकी नॉलेज फिर सब जगह जा रही है। तो सम हाउ 20 ICU मैनेज करके हम अपनी कॉस्ट को सिग्निफिकेंटली कम कर पाएंगे। एंड सेम हैपेंड विद नर्सिस। एंड बिकॉज उसके बाद फिर हम ट्रेनिंग देते रहेंगे। सम हाउ वी प्लान दिस मॉडल। दिस इज बीइंग सक्सेसफुल। इन 6 months वी बिकेम द लार्जेस्ट चेन ऑफ ICUs इन नॉर्थ इंडिया। Another challenge was adoption readiness in peripheral doctors. Peripheral doctors बोल रहे हैं यार हमें तो टेक्नोलॉजी नहीं आती। How to overcome? पहले तो उनको कन्विंस ही करना है कि it's not that tough. But like अजय जी said, that interface has to be very simple. वो टेक्नोलॉजी उतनी टफ नहीं होनी चाहिए। आज हमने जब हमने अपने 2 कैमराज न्यूरो डिपार्टमेंट में और पीडियाट्रिक्स में लगाया. वी टॉक टू द नर्सेज. इनिशियली वी थॉट कि नर्सेज करना ही नहीं चाहती. नहीं, नर्सेज वर हैप्पी, दे वर हैप्पी. वो कह रही सर हमारा तो बहुत काम बच जाएगा उससे. प्रॉब्लम इज वी नीड टू ट्रेन देम, वी नीड टू एक्सप्लेन देम, वी नीड टू. और जब हमने पेरिफेरी के डॉक्टर को सेम मॉडल बताया कि यार तू घर पे आराम से सो सकता है, डॉक्टर की भी जो पर्सनल लाइफ है उसको. फिर आधे लोगों ने सीसीटीवी कैमराज लगा रखे हैं, वो पूरे रात वो सीसीटीवी कैमरा ही देख रहे हैं. दिस इज नॉट डन. क्वालिटी ऑफ लाइफ ऑफ अ डॉक्टर इज अ मेजर इशू. टेक्नोलॉजी को हमारी लाइफ सिंपल बनानी है, टेक्नोलॉजी को हमारी लाइफ हेल्प नहीं बनानी है. हमें अपने फ़ोन पे सीसीटीवी कैमरा लगा के अगर घर में भी वैसे ही उसको देखना पड़ेगा तो फिर हमें और चौकीदार में क्या फ़र्क रहेगा. We need to use technology to make our lives simpler, to make our life good. Adoption readiness and that mindset. हमने लोगों को ट्रेन किया. 20 वर्ष स्टैटिक थी, वो तो समझ नहीं था ये क्या होता है. There was issue of string and server architecture. सर्वर्स के बारे में कोई नॉलेज नहीं. So we told them this is not a big issue. ऐसे बड़े सुन के मर ही जाते हैं कि सेक्रेटरी का क्या हुआ, देन वीआईपी टेक्नोलॉजी के बारे में नहीं बताया. दिस इज अ पेनिट्रेशन टेस्ट जो हम करते हैं, कितना हैकर उसको पेनिट्रेट कर सकता है. तो फोन की ठीक है, देयर वर लेगेसी ब्राउज़र पुराने हैं, बट उसको क्या करना है, उसकी चीज़ों को सिंपल करना है, उसके लिए चीज़ों को कॉम्प्लेक्स नहीं करना है. सो हमने एक ऐसा सॉफ्टवेयर बना लिया which was customizable for every device, which was intuitive, which was easier to use, which made the life of me, my team and our peripheral doctors nice. हमने 20 ICU चलाकर, it is not for money anymore. I was earning much more in a corporate hospital when I was charging 1 lakh for a single patient, and I became consultant at the age of 28. I left that job at the age of 38 when, after being head of department for 10 years, when people start their journey as a consultant, I was earning like anything. But now it's not about money anymore. It's about how we can bring the change. So this was our initiative, and this is my last slide. What is intelligent future? 3 चीज़ें मैं बताऊंगा. Just imagine. One is personalized medicine in diabetes. This is what we have done. ये theory नहीं बता रहा. This is what we have. Just imagine it. Last slide है. सो एक ओपीडी में डायबिटीज़ का पेशेंट आ गया. जस्ट इमेजिन द सिनेरियो. अब डायबिटीज़ के पेशेंट के साथ समस्या क्या हो रही है, आज हमने देखा उसको, और 4 महीने बाद वो आ गया वापस कि सर मेरी तो HbA1c फिर से 9 है. भाई तूने क्या किया? मीठा तो मैं खा ही रहा हूँ, वॉक नहीं कर रहा. प्रॉब्लम कहाँ है? प्रॉब्लम ये है कि हम उसको नज ही नहीं कर पाए. हमारे पास टाइम ही नहीं. 50 की ओपीडी देखेंगे, सिर पहले ही दर्द हो रहा होता. वी नीड टेक्नोलॉजी टू मेक दैट थिंग ईजियर. हमने इससे पहले डायबिटीज़ पे कैप लॉन्च की थी. सो हाउ वी कैन मेक, अब अगर टेक्नोलॉजी हमारा वो वाला काम कर दे जो हमें बोरिंग लगता है कि पहले ही 50 पेशेंट बाहर बैठे हैं और फिर कोई बोले डॉक्टर साहब समझा दो डाइट, हमसे नहीं समझाई जाएगी भाई. टेक्नोलॉजी हैज़ टू डू दैट. नाउ इट हैज़ टू बी पर्सनलाइज. नाउ इमेजिन अ सिनेरियो, आपने पेशेंट आ गया, आपने पेशेंट को एक ऐप डाउनलोड करा दी, और इंटरनेट ऑफ थिंग्स, जब भी आप लोग इमेजिन देखा होगा फेसबुक पे कुछ भी सर्च करोगे और उसके बाद गूगल पे करोगे, फिर वही चीज़ें दिखने लगती है आपको. अगर आप कहीं मॉल में जा रहे हो तो आपको वहीं की नोटिफिकेशन आने लगती है. तो ये ऐसा कुछ नया नहीं था. व्हाट वी डिड, हमने बोला भाई ठीक है, अब तुम्हें हर दिन एक रिमाइंडर आ जाएगा, और अब वो पेशेंट को हर दिन एक डाइट के बारे में रिमाइंडर आ रहा है. अब वो पेशेंट जा रहा है और हमें पता है कि वो जिम उसको 3 दिन वॉक करना है. फॉर एग्जांपल उसको हफ्ते में 5 दिन वॉक करना है. अब वो वॉक नहीं कर रहा, तो आपको पता है कि उसने वॉक नहीं किया बिकॉज वो कनेक्टेड है आपके साथ, और आपकी एक नोटिफिकेशन चली गई कि यार तूने वॉक ही नहीं किया. अब आप उसको पर्सनल लेवल पे नज कर रहे हो, तूने वॉक नहीं किया. वो मॉल गया, आपको पता है बिकॉज जब भी आप मॉल जाते हो आपके मॉल के आसपास की शॉप्स की नोटिफिकेशन, वी कॉल इट इंटरनेट ऑफ थिंग्स. अब वो मॉल गया, मॉल के पास वो एक दुकान के आगे खड़ा हो गया जहाँ पे मिठाई की दुकान है, और वहाँ पे उसको नोटिफिकेशन चली जाए कि यार तू मिठाई की दुकान के सामने बस मीठा मत खाना. जस्ट इमेजिन हाउ दैट थिंग विल मेक आवर लाइफ सिंपलर, हाउ दैट थिंग विल मेक द लाइव्स एंड आवर ट्रीटमेंट इफेक्टिव. सो दिस इज हाउ इंटेलिजेंट फ्यूचर एंड इंटेलिजेंट टेक्नोलॉजी इज कमिंग. ICU मैनेजमेंट, जस्ट इमेजिन अ सिनेरियो, एक पेशेंट ICU में है, पेशेंट आ गया और
Dr. Verma, if you don't mind, you're very late.
तो सर जस्ट ओके, तो जस्ट ICU मैनेजमेंट में इफ दैट कैन get your Apache score done that can tell you कि अगर आपके पेशेंट को जस्ट 30 सेकंड में 2 स्टोरी से सो पेशेंट CNS का है, आपके रेजिडेंट ने लीवोफ्लॉक्स ऐड किया, उसको पता चल गया कि सीजर होने की पोटेंशियल इतनी है, जैसे ही उसने मेरोपेनम ऐड किया उसको पोटेंशियल चला गया यार ये पहले CNS का पेशेंट है, लीवोफ्लॉक्स प्लस मेरोपेनम ही विल हैव सीजर्स डेफिनेटली, क्योंकि उसकी पास्ट हिस्ट्री भी है. सो दिस इज दैट कैन मेक योर लाइफ इजी. एंड वर्चुअल हेल्थ असिस्टेंट आपने रोबोट देखा, दैट वाज मेड बाय माय कंपनी. जस्ट इमेजिन उस रोबोट के बदले आप हैं एंड यू आर टेकिंग राउंड्स इन ICU एज अ वर्चुअल अवतार. आपको राउंड्स लेने की ज़रूरत नहीं है, यू कैन सिट एट होम एट दैट अवतार कैन टेक राउंड्स ऑन योर बिहाफ. So thank you, it was pleasure talking to you all. Thank you, sir.
Thank you so much. So with that, we come to the end of our panel discussion. Since we're running very late, I don't think so we are going to invite any questions from the floor. I can perhaps take 1 or 2 comments if anybody wants to say anything from the floor, and then we can conclude in the next 2 minutes. Anybody wants to say anything? I'm so sorry that we can't take any questions. I know, there were some questions which were thrown up, but as I said, we're running late. Anyone? Uma? Mr. Kumar, Uma, anyone from the floor wants to say a quick comment? You will have 10 seconds to make your comment. Anybody? Yes, Monica.
So actually I talked to Dr. Vikrant Kavar and he has done few studies. What he wanted to, that's what I'm saying here, that he said that all the technology, they are like really doing well. What our India is lagging behind is that general public is not, not accepting it. They are not knowing it actually. He did some studies where he found that the next door person is also not aware of all these things. So he was like, there should be more emphasis on IEC of public. So,
Digital literacy is equally among the public as it is among the doctors. It's just not one way. I think these are adoption which will take time. The COVID pandemic definitely made things easier, and I think we should take the advantage. There is at least awareness. We've done about 500 million teleconsultations in this country during COVID. It's not a joke. So I think, many are from remote locations. So people are aware now that this technology can be used to their advantage. And, as Amit was saying, how do we nudge the patient to use the technology? He could be standing in front of a sweet shop and say, don't have anything. So you need to use a lot of these things, multiple things. And the challenge to us for doctors is they're very, very good with our medicine, but we don't know these things. And how do we get into that mind of the patient and change that? And that's going to be our biggest challenge, how to get the technology adopted and how the patient is going to take it, obviously. So we need a lot of patient studies as well, in this. So I think India is a good example. We're doing the right things. I hope there's not another pandemic, but if there is another pandemic which happens, we do have a lot of experience. And I think technology is being a great savior for us. Any more comments? Yeah, Dr. Kim, please.
I just wanted to say we had a wonderful compilation of use cases. All the speakers gave wonderful use cases today. It's just for the youngsters to understand this and the technology that you have. You are more familiar with the newer technologies that are coming in. How do you integrate, how do you marry them together for the benefit of the society is what you have to think. I think it's in your hands.
Definitely. Thank you. Thank you very much. Thank you, my panelists. Yeah, some of you, if you want to become members of Telemedicine Society, do have student membership. So do participate and you can graduate to full member after that. Thank you. Shyam.
Thank you all the panelists and our coordinator Dr. Sunil Shroff. So now we head on with the demonstration of the equipments that we are using in the telemedicine. The first one is the AIIMS. It's a digital stethoscope, and Mr. Ali and Mr. Jimson George will be coming to talk about it.
Hello all, I am Ali and Jensen from AIIMS. we have developed a module that you can connect conventional stethoscope so that you can analyze, record and share audio in real time. This device connects via Bluetooth to mobile and laptop. You can so that you can share sounds for real-time auscultation. Also, it has got AI features so that you can analyze the sounds.
Yeah, so basically you can record, like in conventional state you can just listen to the sounds. Here you can convert the analog signals into a digital signal and record the sounds, and you can share it with anyone. And we have a feature called IO Real Time. In this, through internet you can directly live stream the heart sound and lung sounds through internet. And we have SDK and API supports to integrate with existing telemedicine systems. So these are a few clienteles which are currently using the live streaming feature.
Healthcare will become affordable to the patient. Then healthcare will become accessible to the patient. ಈಗ ಸ್ಟೆಥೋಸ್ಕೋಪ್ ಹಾಕಿದ್ರೆ ರಿಮೋಟ್ ಮಾನಿಟರ್ ಮಾಡುವ ಡಾಕ್ಟರ್ಗೆ ಸ್ಟೆಥೋಸ್ಕೋಪ್.
So there was Dr. Devi Shetty, chairman of Narayan Health. So this is a center in Bangalore, Smart City project, where our device is used to, it's hub and spoke model, where you keep the device in the PHC and it goes to the main hub. Doctors sit there and visually see the graphs and give the diagnosis there. And currently we have done 9 lakh plus screenings and 75,000 plus auscultations. 60,000 plus heart filters are used. We have like 2 filters in the device, heart filter and lung filters. So 9,000 plus reports also has been generated. In report you will get a phonogram report, which in like using AI you can like see which is S1, S2 and systole and diastole in the phonograms. Then 11,000 plus live streamings which are used by telemedicine companies has been done. So during COVID, this was our innovation, like this was the use case. So here you can see a baby and the mother, the device is with them. So the mother is keeping the device on the baby. And the doctor is sitting far away with the mobile and he can listen to the sounds wirelessly without any contact. So we participate in multiple conferences. So there we get like good response from doctors. Doctors directly buy. So now we are concentrating mainly on B2C also. So that is how we met Dr. Rita Dadwal in Telemedicine Goa. So we are like the device is patented in 60 plus countries. Recently in February we were in Shark Tank season 2 also. Thank you.
Thank you. The second demonstration will be on eye clinic, and Mr. Saurabh Darda, Vice President Remedio Company, will be coming and will talk about it.
Good evening, everyone. I would like to first thank the TSI officers for inviting us and giving us the opportunity to present on our tele-ophthalmology devices. So, I will be presenting on the topic, the reach the eyes with the videos eye clinic in a bag. So, just for the visual representation, I have put it here as in the bag over here. So, Remedio is an ophthalmic device company. It is from Bangalore, and we are enabling early detection of eye diseases using innovative, affordable, simple to use and portable devices which are integrated with tele-ophthalmology and AI. So, we have a presence in 20 plus countries and more than 3,000 plus installations are there. As I remember, like Dr. Kim sir told that like the OPD is mostly, it's kind of a reactive one where the patients which are coming and the doctors are dealing on that part. So here the same problem, like to provide eye care services at the last mile, where there are no doctors. So there is like one ophthalmologist for every 1 lakh people globally. So you can see on the slide that in India itself there are like retinal diseases cases more than 30 million, refractive error cases 170 million, cataract more than 70 million cases. Now the problem is that to scale up the operation for the eye care services, the devices are very bulky and a lot of infrastructure dependency is there. So how to scale up? So there comes the Remedio offering. So we have a eye clinic bag which enables last mile screening, which all the devices are in a kind of a backpack, and this bag just weighs less than 5 kg and it can be used by anyone, and it works without internet, and with minimal training anybody can use it. So I will first go through quickly about like what are the 4 devices in this bag, and then I will show you a quick video. So we have the first device as a retinal camera which takes images undilated. So it is again a portable and lightweight, and it has been integrated with AI for diabetic retinopathy, glaucoma and AMD, all the referable ones. So, and that doesn't require any internet. So with a single tap we can generate 3 reports for referable diabetic retinopathy, referable glaucoma and referable AMD. So we have done the multiple studies where you can see on the table the sensitivity and the specificity for everyone, where sensitivity is everywhere 93% and above. So we have like around 170 plus devices in